So, the most common pancreatic disease that requires the pharmacological therapy is basically diabetes mellitus, which is a deficiency of insulin production or its effect. So, diabetes it is treated with with several parenteral formulations of insulin and oral or parenteral non-insulin anti-diabetic agents. So, let's start with the brief introduction of the diabetes mellitus. Diabetes mellitus is a disorder of a pancreas, and it is divided into four major categories: type 1, type 2, type 3, which is also known as gestational diabetes mellitus, and type 4, which is a category of others. So, in type 1, we have So in type 1, we have this diabetes is due to the autoimmune beta cell destruction. So there is destruction of beta cells in the pancreas, and the process is basically autoimmune. And this kind of diabetes is usually dependent on the people who have type 1 diabetes, they are dependent on insulin. The type 2 diabetes is due to a progressive loss of beta 2 activity. So these are the patients who are usually on oral hypoglycemics during the initial phases of their disease, and later they may require insulin as well. So there is a progressive loss of beta cell function of the pancreas. In type 3 diabetes, this is gestational diabetes, and it is diagnosed in the second or third trimester of pregnancy. And this diabetes, it was not present before gestation. So it is usually diagnosed in the third and the fourth trimester of the pregnancy. Type 4 diabetes, it includes modified, or it is the which is also known as MODY, which is majority onset diabetes of the young. It also includes any pancreatic diseases which can cause diabetes or an insufficient release of insulin. It also includes a drug induced diabetes, which is usually caused by any immunosuppressant drugs. So all and also diabetes that is associated with other syndromes that after transplantation. So this category type 4, it contains all the other causes of pancreatic diseases apart from type 1, type 2, type 3, and type 4. So in order to better understand which kind of anti diabetic drugs or agents are used, we must have a brief introduction of kinds of diabetes mellitus, in which in order to better understand the mechanism. So let's start with the insulin, which is the most and which is the foremost drug that is used in the treatment of diabetes. So insulin is a hormone that is secreted by the beta cells of the pancreas. Physiologically, it is synthesized as a prohormone, which is called as proinsulin, which is a very long amino acid peptide, polypeptide. It has 86 amino acids, and this is broken down, or this is cleaved into two amino acids, two small chain amino acids, in which one is called as a C peptide and one is the insulin. So this proinsulin, it is converted into insulin and and C peptide. The C peptide, it does not have any physiological role, or it might have an physiological role, but we are unaware of that. And this insulin, which is a 51 peptide chains, it has 51 amino acids. So this is how the insulin is synthesized in the body. It has important effects on almost every tissue of the body. And the insulin receptor, which is a transmembrane receptor, insulin receptors are found in the membranes, and what insulin does is that it goes and bind with these receptors. These receptors are tyrosine kinase, and what actually happens that they are phosphorylated, becomes phosphorylated after the interaction with the insulin, and then there is a variety of them. There is they activate many other systems as well. This is how they activate other systems as well. This is how the insulin works or has an effect on these cells. So insulin, it acts on almost all the body tissues, and the major organs on which it has effect are liver, skeletal muscles, and adipose tissue. So we'll start with the liver. What it does in the liver is that it increases the storage of glucose, which means that this process is known as synthesis of glycogen and gluconeogenesis. Now, in the liver, it also decreases the protein catabolism, increases triglyceride synthesis, and VLDL formation, which is a very low density lipoprotein formation. So, in the skeletal muscles, what it does that it stimulates the synthesis of glycogen. So here, the glycogen is also synthesized, and it also causes an increase in the protein synthesis. So proteins, they're also synthesized in the muscles by the help of insulin. In the adipose tissue, it facilitates the triglyceride storage by activating the plasma lipoprotein enzyme, which is called as lipase. This enzyme, what it does that it increases or it facilitates the triglyceride storage. The triglycerides, they are stored in the adipose tissue by the help of insulin, and it also increases the glucose transport into the cells. The major actions of the insulin are on these organs, these major organs, and this is how it has its impact in the body. So this was all about the physiological actions of the insulin. Let's discuss the commercially or the pharmaceutical insulin preparations that are in the market that we use nowadays. So the insulin, it has, so we have four kinds of insulin. We have rapid acting, short acting, intermediate, longer acting insulin. In the rapid acting insulin, we have a mnemonic which is called as lag, which means it has three kinds of insulins. Number one is Lispro, Aspart, and Glulicine. So these are the three kinds of insulin that are rapid acting. Apart from these, there is another insulin which is an inhaled insulin. It also has a very rapid onset of action, and it comes under the category of rapid acting insulin. In the short acting insulin, we have insulin which is called as insulin R, or it is also called as regular insulin. In the intermediate acting, we have insulin NPH, which is also called as neutral protamine H-DON. So this is the kind of insulin which has an intermediate onset of action. And then we have long-acting insulin. The mnemonic of long-acting insulin is DDG, which means it has dedimer, it has glargine, and the third kind is D-gludec. So these are the three insulins that are longer acting insulins, and these are the three insulins which are rapid acting insulins. Now, the shorter acting or the rapid acting, as the name indicates, they have a very quick onset of action, which means that they will start acting, or their onset of action occurs in 15 to 30 minutes, which means they have a very rapid onset of action, and they must be administered 15 minutes before the meal. The short acting insulin or the insulin R, it has a little bit of it has a short acting, it has a rapid action, but little more greater than the rapid acting. So they act in 30 to 60 minutes. The intermediate acting insulins, they start their action after 1 to 2 hours. So they have to be administered 1 to 2 hours before the meal. And the longer acting insulin, they have an effect. The Detimer, it has an effect of 2 to 4 hours. The glargine, it causes the effect in 1 to 2 hours, and the decludec, it also causes an onset in 1 to 2 hours. So this is how they all start their action in the body. Now the rapid acting insulin, they have a shorter duration of action, and they have a total duration of action of 1 to 3 hours. The short acting or the regular insulin, it has a duration of action of around 4 to 6 hours. The intermediate action, it has a duration of action of 10 to 20 hours. And the long acting, they vary in their action. The Detimer, it has a duration of 6 to 24 hours. The Glargine, it has duration of action of 24 hours, and the Decludec, it is the longest acting among all the insulins, and it has a duration of action of 24 to 42 hours. So this is the longest acting insulin. So this is how the insulins, they vary in their onset, duration, and the time of administration of all these insulins. So now among all these insulins, the longer acting insulins, Glargine and Degludec, they are also called as peakless because they maintain a steady state of insulin and they do not cause hypoglycemia because they do not give any peak of insulin. So these are the most recent and the most advanced kind of insulins. Now, how we manage the insulin therapy in the patients or in the diabetes mellitus patients. So this is the management of insulin therapy. The first step in insulin therapy is to calculate the TDI. TDI is total dose of insulin or total daily requirement of insulin. So this is a total dose of insulin, and it is a weight based calculation. We calculate is by the formula 0.3 to 0.6 kgs. Sorry, 0.3 to 0.6 units per kg per day. So this is how we calculate the TDI, and it is usually the first step in the management of insulin. The requirements, they may be higher if we're treating DKA or if the initial diagnosis of during the initial diagnosis of diabetes mellitus, usually the glucose levels of the blood are quite high. So the concentration or the unit of insulin that is required in those conditions is usually high, but usually the TDI is 0.3 to 0.6 units per kg per day. So in order to manage insulin therapy in any patient, the first step is usually to manage is to calculate the TDI. So after you have calculated the TDI, there are two methods. There is an older method in which we used to use NPH in regular insulin, and then there is a basal bolus insulin therapy, which is a more recent method of managing the insulin in patients. So we'll start with the older formulations. In the older formulations, what we used to do is that the first step is always the same, that we calculate the TDI, and then with the older formulations in which we used NPH and insulin R, what we used to do that we calculated the TDI, and when the TDI is calculated by the formula, 2/3 of this insulin. Now, this 2/3 of this insulin, it is usually given before the morning meal. And the 1/3 of this is given as before the evening meal. So now that we have calculated the TDI, we give two-thirds before the morning meal and one-third is given in the evening meal. Now this two-third that we give before the morning meal, two-third of this can be given as NPH and one-third can be given as regular insulin. So this is how the older formulations of insulin we used to be given in order to treat the diabetes mellitus. The one-third that is given before the evening meal is usually given in a 1:1 ratio, that we give half as NPH and half we give insulin R. So the most recent or the most current method of management of insulin is called as basal bolus insulin therapy, in which what we do, the first step is same, that we calculate the TDI and then we divide this TDI into two parts. 50% is given as bolus therapy, you give as a bolus, and 50% is given as basal. Now the basal insulin is quite easy, so we'll cover it first. The basal insulin is usually a longer acting insulin formulation, and it could be Clargine, it could be Detamar, or it could be Degludec. And the 50% of, let's say if the person has a total daily insulin requirement of 20 units, so we'll give 10 units in the bolus form and we'll give the rest of the 10 units as the basal insulin. So we'll give, and the bolus insulin, it is usually split three ways, that we divide this bolus insulin to be given before every meal. Now the advantages of this basal bolus insulin therapy is this, that this method is usually more physiologic. It causes less hypoglycemia and it is more flexible to the patient meal times. However, it does have some disadvantages as well, which means that the cost and the increased frequency and number of daily injections, which can be troublesome to the patients. So we must note that the same process of basal bolus insulin therapy can be applied to a patient with type 2 diabetes as well, who is receiving intensive insulin therapy with or without oral diabetic medications. Now there is a concept of correctional insulin needs as well. So the patient, apart from there are patients who are taking basal and bolus insulins, and regardless their insulin concentrations, their glycemic control is not well controlled. So they have hyperglycemic exertions despite optimal basal bolus therapy. So there is a rule which is called as correctional insulin need rule, and it is called as 1800 rule, in which what we do is that we divide 1800 by the TDI, which is the total daily dose of insulin, and it gives us the milligram per deciliter of glucose that will be lowered by 1 unit of rapid acting insulin. For example, if we say that we have the TDI of any patient is 30, so we will divide 1800 by 30, and now the answer will be which means that 1 unit of insulin will lower the blood pressure, will lower the blood glucose level of this patient by 60 milligram per deciliter. So this is the concept of correctional insulin, and this is also known as insulin sensitivity factor. So this was all about the insulin. There are various methods of glucose monitoring as well. There is real-time glucose monitoring, and then there is intermittent glucose monitoring, which is more common in the patients. Now, the delivery of insulin is usually subcutaneous, and it is usually given, sometimes it is given in the form of prefilled syringes, and sometimes insulin pumps are also used. So, this is how the insulins are given. So, whenever you're treating or whenever you're managing a patient on insulin, you must know the goals for fasting and postprandial glucose concentrations. Identify when the patient is at goal and when the patient is not at goal. So look for the consistent trends rather than isolated events, which means that do not look for any one isolated or any one change in reading apart, regardless of any one isolated event. Look for any consistent trend. So this is the goal, or this is the key in management of insulin in patients. Now we have another thing which is related to the insulin, which is called as an amylin analog. Now, amylin is usually co-secreted with insulin. It has a similar and it has effects that are similar to that of GLP-1 agonist. So, GLP-1 agonist, what they does is that they delays the gastric emptying time, and they improves satiety, which means that the patients they feel full after a meal for a longer time, and this is how they control the BSL in patients. So amylin, it is usually co-secreted with insulin. We have some amylin analogs, and there's only one analog that is available in the market, and it is called as pramlintide. Now there's only one amylin analog that is available in the market, and it is used in type 1 and type 2, both kind of diabetes, type 1 and type 2 diabetes. In type 1 diabetes, usually low doses are used. We start with 15 mcg of subcutaneous injection, and we can go up to 60 mcg. Whereas in type 2 diabetes, the initial goal or initial dose is 60 mcg, and we can go up to 120 mcg with each meal. The dosages, this should be titrated in intervals of the initial dose. For example, if you started 15 mcg of patient of amylin or pramlintide in one patient, so increase the dose in 15 mcg increments over a period of time. Do not rapidly increase the doses. So, use of pre-filled pens are strongly recommended. So, whenever possible, use a syringe rather than a vial. However, amylin analogs, they also have some adverse effects, and they have a black box warning for hypoglycemia, which means that they can cause hypoglycemia in patients. So we must keep this in mind while prescribing the patient's pramlintide. They also causes GI symptoms, including nausea and vomiting, anorexia, headache. And these drugs, they are contraindicated in patients who have substantial gastroparesis, which means that if the patient already has gastroparesis, do not give them drugs which are going to further prolong the gastric emptying time. And also in any patient who the patients who are usually unaware of their hypoglycemia or do not have any symptoms of hypoglycemia, we will not prescribe them these amylin analogs because they are very notorious for causing the hypoglycemia.